Okay, everybody, hello.
Heureux d'être
I'm
ici
very
parmi
happy
vous.
to be with you today.
Bon, pour moi, c'est une histoire aussi particulière avec
It's a
OrthoPartner parce
very
que,
special story between
pour
me
ma
and
part,
Auto Partners
j'ai toujours
because
cette croyance
I
que
believe
nous
very
sommes les
much
maîtres,
that
c'est à
we
nous
are
de
the
développer notre
masters and it's our
biomécanique et
job to
d'aller de
develop the
l'avant. Et
biomechanics,
l'outil, il est
and
là pour maximiser les chances d'avoir les
the
meilleurs
tools
résultats
are there
possibles.
simply to
Et,
offer us a chance
comme
of
je dis
having the
toujours,
best
un
possible
outil, c'est un
results. And
moyen
as
pour
I
un
say, a
orthodontiste pour
tool
achever
is a
en fait
way for an
ses objectifs
orthodontist
de traitement.
to
Alors, je
achieve
suis passé par
the
différents types
treatment
d'outils
objective.
et
I've
à un
used
certain
different
moment de ma
kinds of
carrière, il y a
tools,
eu
and there
cette
was a stage in my
option,
career when I had
ambition en
the
fait d'aller
option,
un peu plus
the
de l'avant,
ambition
de
rather,
développer
to
beaucoup plus
move
mécanique
things forward and develop an efficient mechanical system
c'est
and
en fait le
be
mot d'ordre.
predictable.
Et
Being
au bout d'un certain
predictable
temps,
is
j'ai
the
essayé un
motto.
certain nombre de
And after a
techniques
while, I tried a
différentes.
few
Et puis,
self-ligating
beaucoup avec
techniques, and I ended up with
développé, ça m'a
Genius.
donné une entière
And
satisfaction.
Genius
Et maintenant, j'ai essayé de développer un peu
is
plus.
satisfactory.
Aujourd'hui, des mini-vis,
I
par leur
believe today that mini
simplicité, ça
screws,
apporte un
TADs,
avantage indéniable dans notre pratique.
provide
Ça
us
permet en
with
fait de résoudre
an
des situations
undisputable
que
advantage,
biomécaniquement nous empêchaient
and
d'aller.
it helps us
Alors, on va
solve
voir
situations which
comment
biomechanically we're stuck with.
on peut
So I'll show
connecter
you how to
cette
push
une
back the
mise en
limits,
point
but
tout d'abord sur
honestly,
les limites, parce que
it's
franchement,
about
c'est vraiment
pushing the
important pour nous
limits
orthodontistes de
away.
maîtriser les
For us
limites et
orthodontists,
de
it's very
voir
important that we
réellement
comply
ce
with
qu'on
the
peut
limits
faire,
and
mais ce
see
qu'on n'a
what we
nous
can
n'avons
do,
pas le droit de faire.
but also what
Et
we're not
étant
allowed to do.
médecin, je crois qu'il y a des limites
As doctors
pour
or healthcare
respecter ces limites anatomiques.
practitioners, we have
C'est-à-dire
to
qu'on ne peut
comply
pas
with the
déplacer les dents
anatomical
au-delà de
limitations.
leur
We cannot move the
support osseux
teeth
et parodontal.
beyond
Et
their
c'est une
periodontal
notion que
and
je
bone
dis, il y a
support.
cette notion de
I like
contenu
to
et de
say
contenant,
it's a
et
matter
on n'a
of
pas le droit d'aller
content
au-delà
and
de ça.
container, and we cannot
Première
push the
règle,
limits
c'est qu'on va
beyond the
respecter
container limits.
l'anatomie
So rule number
et
one,
biologique,
comply
mais
with
par
the
contre, ce que nous
biological
devons faire,
anatomical
c'est pousser
limitations.
les limites biomécaniques.
Rule number
Ça,
two
c'est
is
notre
we
rôle à nous
can
en tant
push the
qu'orthodontistes de voir comment on
biomechanical
arrive, vous savez,
limitations.
à maximiser cette
And
chance d'avoir les
we
meilleurs
need to
résultats
understand how
possibles.
to
Et avoir
maximize
ce
those rules to
contrôle
obtain the best possible
dont,
result and
que nous souhaitons
achieve
tous
the
avoir
control
pour
that we
avoir
all
ces
want to
résultats.
achieve to get
Alors,
these
ce qui se passe
results.
souvent, et c'est, je pense
Very
que
often,
Ariel en a parlé,
and this
le
is what
Boeing
my friend
effect,
Ariella said, we have the Boeing
pour
effect.
citer un peu la bête noire,
And this Boeing effect is like the black sheep for us orthodontics, parasite movements that happen in the transversal dimension or the vertical dimension. This vertical issue that will make it more complicated to achieve good results, and we end up with an overbite at the end of the treatment. And mini screws not only help us with the anchorage, but they also help us with the vertical dimension, but not just. We will see that for the vertical dimension, we can solve issues that years ago we would immediately refer to the surgeon, but now we can do it without surgery, and we can solve the problems only with orthodontic methods. Let's start with the dimension that has the biggest impact on our daily practice, the vertical dimension. And mini screws can provide the vertical vector that will help us achieve control. Let's start with the beginning. We must make a few reminders regarding biomechanics, except that we work away from the center of resistance. And when we place a bracket, we develop moments of force, and the moments will take precedence over the torque, the moment. And we need to do this simple. Those moments cannot be avoided, so they're there to stay. But if we are able to control them and reduce them, those moments, then maybe we will be in a better position. So we should always start with the concept of light forces, and that's what I like about the Genius. By developing light forces, we have low moments, and therefore we can develop biomechanical or force systems with counter moments, and counter moments are the wire, the arch wire, and the bracket. And a well-dimensioned, a well-sized bracket will provide us with this interesting pair. If we look at the literature and we talk about the optimal force, today we know that some studies have shown it, with 18 grams we can move a cuspid. So what would be the point of using very high forces? The higher the force, the more the undesirable moment will be present. When we talk about pushing back the biomechanical limitations, we have to use tools that will limit the parasite effects. And by doing that, you'll be able to develop the right side of mechanics. Regarding the traction, we have 4 premolar extractions. With the mini screws, we can provide better anchorage. And mini screws have replaced the head masks. And they can help us develop all the kinds of mechanics, high, low forces, with a good control over the occlusal plane. We no longer need to retract teeth in 2 stages. You don't have to start with the cuspids and then close the space for the 4 maxillary incisors. You can do it, and that we have in the literature, the systematic reviews. With the mini screws, we can do this in 1 stage, and by allowing non-frictional mechanics, we no longer need excessive forces to achieve this kind of movement. We can limit ourselves to reasonable forces, and we can preserve the anchorage. So on Genius, and that's my protocol, which I would like to share, we start with leveling, rotation correction, and now what is new with the advanced Genius, with 1818, is that we develop interesting moments and couples. We can control the types, the tip, and we can impact the position of the root. And then we prepare for retraction, because in friction mechanics, friction-based mechanics, non-friction-based mechanics, so we have a loss of torque. So we need to be prepared. And we do it because we have an undersized bracket, therefore good torque control. We can do this with 1825, the best is 1925 thermal, and stainless steel. Because stainless steel for torsion couple is the most efficient. According to the studies, we're talking 3 times more than the night eye. So here, once that is done, we can turn towards a sliding optimization. And mini screws will help us with the anchorage, but they also provide us the vertical moment, which will control the occlusal plane anterior, occlusal plane. We no longer fear to lose torque in the anterior area, because the mini screws will deal with that. And a very simple biomechanical rule applies. You have to be close to the center of resistance to minimize the rabbiting movement. So we undersize the arch wire and we go to 1725 stainless steel. Smile before and after. And what I believe is important here is that we have to have an impact on the profile. With this kind of correction, I've seen it done without extractions, but here we're really talking about repositioning the profile. It's also going to have an impact on labial support. And extractions can be still indicated in some cases when you really want to achieve good results for bilabial profile. Today with the mini screws we have better control on the occlusal plane, and that will allow us to push the biomechanics further. It's non-cooperative movement. It's mini screws doing the job, not the patient. And even for cost, mini screws are not having a big financial impact on the price of the treatment. I'd like to go over slightly more complex cases, class 2s in a patient who is still growing. I often have an issue with uncooperative patients, so I try to do my best not to depend on the patient's cooperation. This is the 13-year-old boy with retrognathia, mandibular retrognathia, and I try to use the McNamara technique and Bacchetti's technique. And here you see the stage of maturation of the cerebral vertebrae, stage 4. So it's a pre-puberty peak, and we can hope to have still a skeletal effect. And then there will also be dentoalveolar effects, and that has been confirmed by systematic studies in the literature. However, we should try and take advantage of the growth when it's still there and introduce a new concept, that of mandibular adjustment. If you base your therapeutic strategy on a mandibular growth, it doesn't always work, and it doesn't comply with the science data. But you have to think about adjustment, adaptation joint, dentoalveolar, and occlusal adaptation. Let's start with the beginning. The mandible is locked. And one of the main locks that we need to address here is the transversal dimension. I continue performing disjunction. It works. And it also helps open up the nose again, making the nose permeable again. So we prepare for mandibular advancement, and I use propulsors. They don't rely on the patient's cooperation, and they can activate growth on the condyles. Now, mandibular propulsion devices, that's biomechanical. As far as the anchorage units are concerned, the devices create a anti-clockwise tilt, and you may have consequences when the mechanics are not well controlled, and the mini screws will provide control. Here the mini screws are extravedicular, and I can control my anterior occlusal plane with the mini screws when the propulsion device boosts the mandible forward. I add an anti-SP curve in order to maximize the effect, and here the mini screws could have been placed between the roots. But I thought, okay, if this fails, I have my mini screws outside of the roots and I can distalize the maxillary arch. So always anticipate. Cephalometric X-ray before and after the mandibular propulsion phase. You have to reorient the occlusal plane in such a way that you stabilize the results you have achieved, and you make sure the jaw is in a good forward position. This is the work with the bite blocks, bite ramps. You have anterior occlusal plane control in order to control the overjet and the deep bite. And the bite ramps will push the mandible forward. This will create intra-articular compressions for condylar remodeling, and it will help you reconstruct the posterior area with light elastics to control the propulsion. That is the case once finished. Here are the patient's photographs. Not a big change because the growth was limited, but we have a good mandibular adjustment, and the class 3 has been corrected. That's something I really want to share with you. The mini screws positioned outside of the roots, that complies with some very specific protocols. You cannot position the mini screws without cone beams. The mini screws are placed under the sinus. We have two obligations. One, be outside of the roots, away from the roots. That's been described in the literature. It can cause maxillary movement with an anti-clockwise tilt. And the second obligation is be away from the roots. In a systematic review, we estimated that there are so many architectural variations in the infrazygomatic arches, and we really tried to start a bicortical anchorage. We have a 2 to 5 millimeter window here, so it's impossible to start working on the insertions without using mini screws. I mean, that's really something I need to insist on. Here we have two strategies. It's very difficult because we have the bicortical engagement. With the sinus floor, you don't want to puncture and perforate. But at least if you stay a couple of millimeters away, you're safe. We really need to do more studies. I hope it's going to be published soon. We are suggesting good practice guidelines for mini screw positioning, and that could be helpful to help you understand and remember that there are rules and they need to be complied with. And there is even a legal issue here so that you place your mini screws in the appropriate position. What can you do with the mini screws? Well, you can use them for distalization in situations where you want to distalize without changing the patient's profile. You can take advantage of the mini screws placed away from the roots to open more space, and You can address this kind of situation without extractions when you just want to distalize, for instance, a class 2 due to bad molar positioning. And also you have more complex situations like this one, where you can recreate space with the help of indirect anchorage. Now that's a complex case. There's an impacted cuspid. The premolars are positioned more towards the palate, and on the cone beam you see that the cuspid has resorbed the lateral tooth root. It's also very important that you do the x-rays and the cone beams before you do anything else. And you can use mini screws with an indirect anchorage system to open space for the premolars, to level the curvus B with light elastics. I don't want to anchor myself on the molar because I don't want the molar to become too mesialized. So, you can use all kinds of biomechanical rules. I mean, they're all very helpful with mini screws. Again, this is the parasite effect of mini screws. They're going to tilt the occlusal plane so we can add some class 3 elastics to maintain the posterior area, and the finishing phase is quite satisfactory for such a complex case. And sometimes we need to restore the pre-prosthetic occlusal height or vertical dimension. So we have palatal mini screws to provide more vertical dimension. We have open bites or posterior mandible rotations with class 3 elastics on mini screws. You can straighten up and control the mandibular plane. It's all kinds of biomechanical rules that can be helpful, provided you know how to position them and provided you have carried out a preliminary study to avoid the main anatomical obstacle, the sinus wall. Here we have screws that you want to move away from the lateral tooth, and that is also helpful to solve the problems and pull down impacted cuspids. Now, another limitation, the transversal dimension. Again, that's the big discussion. Disjunction, no disjunction, expansion, no expansion, with or without brackets. There are limitations you need to comply with, otherwise there is a danger of dehiscence. Maxillary rapid disjunction allows to move apart the two halves of the maxilla, but what effect do we get? Again, there's a discussion. Do we get dental-alveolar effects or skeletal effects? Mostly puberty will orient you towards the right decision, but you really have to be accurate and know exactly what you're trying to achieve. Quick reminder, there are 3 types, 3 stages, even 5 stages. There's one stage with this very strong interdigitation, partial or total fusion of the suture, and in that case you cannot obtain a disjunction. If you want rapid disjunction, there will be more interalveolar effect than skeletal effect, and that means you're going to have periodontal tissue consequences, and it's going to have an impact on the vertical dimension. It's going to extrude the molars. Mini screws can provide solutions. This case is a patient who came to my clinic with a unilateral crossbite. Same question again. Expansion, distraction, or brackets. And if you look at the class 2 and the consequence of the lack of transverse dimension, sometimes the studies will orient you towards different cervical maturation stages. I've read some of those articles. What it boils down to is that in CS1, CS2, and CS3 there is more dental-alveolar effect than skeletal effect. But CS4, we don't know. It's give or take. We have seen patients with CS4, CS5 with a partial fusion of the intermaxillary suture, and we don't know exactly whether to do disjunction or not. But again, a disjunction at that age may have dental alveolar effects more than skeletal effects. What is recommended is to try to do a cone beam, because a cone beam will give you a more realistic image. When I see such dehiscences, here we have a spatial reconstruction with the maxillary molars which are tipped. I'm not tempted to do a bracket-based disjunction or even rapid disjunction by resting on the molars. I really want to do it differently. And this is confirmed to me when I do a coronal section that I don't have enough bone here. I'm not going to move outside of the bone. And if you look at the axial sections, you see the suture partially closed already. So this decision here is obvious. Either you perform a surgical disjunction or it's achieved with the mini screws. Now, my protocol, I use the Professor Onwood's MSc. It's rather interesting. And it allows to achieve distraction of the two halves of the maxilla. Bands are used to position the distraction device. The bands are not going to achieve the disjunction. Disjunction will be done by 4 mini screws. 4 mini screws with bicortical anchorage, very important. You use the two corticals, the palatal and the nasal floor wall. Then you can start doing your job with the rest of the device. But you need to know the limitations so that you can be accurate and take the good decision. The bicortical anchorage, you can split the sutures in a parallel way. You're very close to the center of resistance. And again, bicortical anchorage is helpful to separate the pterygomaxillary junction. That's exactly what you're trying to achieve if you're trying to achieve a skeletal effect. You check with a cone beam, but I don't want to ask for too many cone beams. I only do so if I have a doubt. If my insertion does not match my desires, my wishes, when I have a doubt on the bicortical engagement, I ask for a control cone beam. And that will help me be always on the safe side. This is a patient who was treated with a distraction device, sorry. Here she has maxillary endognasia, and I cannot imagine doing anything that will hurt the periodontal tissue, so I start with distraction. I increase the transversal dimension, and then I will finish the job with the brackets. And we see that once the distraction has been achieved, we can keep the disjunction device in place. I remove the bands because the bands were only there to guide the movements up, but I leave the disjunction device in place as long as I don't have mature bone. And in the meantime, I work with the genius brackets, so I continue the work. Torque correction, arch shape correction, and it's going to be relatively quick. And on this particular patient, there was no bicortical anchorage, but on the left-hand side. And so here we see the molar tipping. That's a parasite effect. And it's very delicate. What I'm trying to achieve is how to turn this into a protocol and make sure that we have bicortical anchorage. It's rather interesting all the same, because it allows to stay away from parasite movements and movements that are bad for the periodontal tissues.
With OrthoPartner, we also try to develop the use of TARS, and we try to develop a kit which is going to help with the use of TARS. That's the 4.2 concept. We are going to develop a new biomechanical approach, so obviously we try to remain as far away as possible from the roots for reference from SKUs. And this is, of course, going to, MSc you need two different lengths, 11 and 13 millimeters, but then again, there's not a one-size-fits-all. We are going again to try and have an evidence-based selection tool for the best length. Those are the main sites where you should place your TARDs if you want to fully leverage the partner. So this is what we want to call a starter kit. Again, 4 SKUs, 4 different lengths, and again, we can provide you with a number of decision-making trees. We also do in-practice training in Tunis in my clinic. I think what is also important is the workshop that we organize on radiographs. We see many TARDs being placed in my country, but what we see as well is that they have been placed without radiograph being performed prior. And yet I think it's key that you do a radiograph in order to know the length of the screw that you are going to insert and what is going to best insertion path. This is also what is going to help you insert the screw with bicortical engagement. With that, thank you, Dr. Labidi. That was extremely interesting. Does someone have a question? Is the distraction painful? Is it painful for the patient, the distraction? Well, perioperatively, it's not very painful, but when you place the device, when you close to the nasal spine, the patient usually tells you that they feel the urge to sneeze. But I prepare my patients properly. I give them painkillers before we start, but also I warn them that the afternoon that is going to follow is going to be rather uncomfortable. I just warn them that they are going to be uncomfortable for a couple of hours. I've learned the hard way that well, you need to prepare your patients. So YAMEN created this protocol for adults with procline teeth. You need to have 4 to 6 turns until you get an anti-incisor diastema, and afterwards you reduce the number of activations. Thank you. A last question. Thank you very much. So 2 questions. Personally, I used to do a lot of expansion, but I know, or rather, TARDs. I used to use TARDs, and I would like to say that the patients would say that they are painful for about 48 hours. And then I realized that the follow-up is more complex than conventional surgical expansion. So I used to use the moon protocol quite a bit, but I sort of stopped. You do come across a number of issues with the rapid palatal extension. I do see an impact on the nose and the width of the nose. So I'd rather go for a number of osteotomies, and those osteotomies are, of course, not as expensive. I would be LF4, for example. So, surgery is also an option. You should not exclude surgery, because I would say that the follow-up is easier. Now, my second comment, well, I concur with you. You need the radiographs, you need the front radiographs, and sometimes you come across a number of issues. When you have a crossbite, usually you have a retruded chin. And so you need to be extra careful with those type of profiles. I know that tomorrow there will be a presentation on sleep. Sleep is something that you need to take into consideration, and I do not treat the patient the same way, whether they have sleep apnea or whether they have good sleep. I performed a study on children when you have a number of situations when they have an open bite. Open bite, 100% of patients with sleep apnea. It's highly correlated. My daughter is a medical doctor, and she concluded that when you have a class 2, there's no direct correlation between having a class 2 and having sleep apnea. However, if you have sleep apnea plus class 2, you know that it's going to help with sleep apnea. Transversal dimension, there's a true correlation between sleep and a lack of transversal dimension. So I would like to argue that we should do more study on sleep on our patients, because it's an interesting part of our diagnosis and thought process. So when your patients come in and they have an underlying sleep condition, usually the tongue is very low, and while you do not manage the tongue position, you know that you're bound to have relapses. So it really helps in our differential diagnosis. And so you need to select and pick the right treatment, especially when you have sleep apnea, I would say. Well, obviously, I agree with what Jean-Baptiste Gerbrat just said. I also read a paper. It's a French paper. I think it's not translated, but never mind. And they reached the same conclusion that you did. It's pretty complex because sleep apnea is not necessarily improved by orthodontic treatment. Now, MSE, I don't think that there are many studies on the positive impact of MSE on sleep, but I tend to agree with you on everything else that you said. Thank you very much.